So first of all, thank you for the phenomenal organization of this workshop. Thank you to Marie-Louise for the invitation. Fantastic opportunity and feel very privileged. So this is joint work with Linda Calaf, my PhD supervisor, now my co-investigator, and Marcel Boya as well, my former co-supervisor and now co-investigator. From Carleton, it's also work joint with Mira Yazbek from the Department of Economics at Ottawa. And I certainly have to thank Mira for introducing me to this intellectually very rewarding and stimulating world of health economics. So thank you. As well, this is joint work with our clinical co-author, David Wensley from the Department of Pediatrics at UBC. And this work started a few years ago, really as sort of a, I would say, plain vanilla kind of biostatistical exercise of David and I, just trying to validate 2 illness severity scores. And thanks to some really meaningful input from Mira and Linda and Marcel, it sort of morphed into trying to have us think about a framework of how we might want to approach sort of larger issues in our medical environment we're working in, which is a pediatric intensive care unit. So just to give an overview of sort of what we have in mind for a research agenda, we want to sort of investigate this broad statement. We want to investigate this relationship between this concept of health status and health utilization. And of course, as you know, something like health utilization is widely studied in health economics. We think of it on a broad level in terms of health utilization in national income, health utilization in technology, health utilization and variations in health utilization in terms of intensities of how we see different practice patterns. Underlying a lot of all of that, of course, is this notion that health status really drives health utilization. Now, the degree to which we can assign an attributable role to health status driving health utilization, of course, that's a fairly open question. I think it's still a question of research in health economics. So we're going to start with thinking of how we're going to work towards defining health status. And we're going to use the concepts, which is the theme of the workshop, of course, of first precision medicine, and initially primarily precision medicine. I think at some point that could probably evolve to personalized medicine, but I'll just be completely frank. When I use the term personalized medicine amongst sort of clinical co-authors or clinical co-investigators, there's a little bit of a hesitation. And that partly comes from the fact that it seems overly ambitious, especially in this kind of medical environment. And secondly, many clinicians feel that there's an ethical connotation, much associated with things like stratified medicine, that really need to be resolved before they're willing to sort of jump into that terminology. And of course, as we've discussed through many of the talks, there's a lot to do to have a common terminology. There's a lot of work to do in terms of saying what we mean by some of these terms. So the reason we want to do all this is, well, we really want to come up with some notion of what an optimal level of health utilization is. We're going to do that in a very specific medical environment. It's going to be the pediatric intensive care unit. And just quickly, this is where what we think is a high value health utilization, but it's also very resource intensive. So just as a roadmap, and we'll see how far we get through everything, sort of want to motivate an economic model that'll require some econometric type of framework for really our clinical analysis in a multi-center setting, and then sort of use all that to think of how we can go forward with a sort of framework for precision medicine in this environment. So in terms of our medical research environment study population, this is the pediatric intensive care unit. It's a unit that takes care of critically ill children aged newborn to 18. So these are not neonates. It's not a neonatal intensive care unit. So it's actually got quite a wide age range. It's really characterized by high levels of acuity and physiologic instability. And really, these last 2 points really start playing in a lot when you want to think of precision medicine in something like the PICU, and that's, we're talking about heterogeneous syndromes rather than being disease specific. And this seems to matter a lot when you want to identify different sort of characteristics of patients. And secondly, as you can imagine, it's an extremely time-sensitive environment where you have rapidly changing clinical trajectories. So we think the PICU could be characterized as high-value care. And this is one area of medical research where we've seen technological innovations, therapeutic innovations really having a dramatic impact. So in this kind of environment, if we think of outcomes as being, for example, mortality, we've seen this huge drop in the last 4 years. Just absolutely remarkable, from about 30 to 40% to really less than 5%. Of course, associated with this is the increase in PICU-acquired comorbidities, but of course that, along with other components of technology, is a separate sort of research issue. And you could compare that with, let's say, adult intensive care units, where despite sort of lower levels of physiologic instability, you're still looking at 30% mortality. That's, of course, understandable in terms of the different patient population. And I think it's important to give sort of this in the back of our mind. This, as economists, of course, we really give a lot of credit to the notion of thinking of things in terms of, let's say, a human capital approach, which suggests that early interventions have long-term consequences. So if we pick it right and we do it right as an early intervention, it's going to have a really good long-term consequence. Of course, if we mismatch, that could be a bad long-term consequence. So the ICU, as you can imagine, is resource-intensive. It's staff-intensive in terms of it being a multidisciplinary care team, things like one-to-one nursing. Of course, technologically, very advanced diagnostics and monitoring, and very technologically dependent and advanced therapies. Virtually all, well, not all, but a large number of the patients are either mechanically ventilated or under some kind of life support. Very high-risk therapies with interventions that are possibly unknown in terms of their therapeutic efficacy, really saying that not all patients will benefit from all interventions, and picking the right intervention for the right patient is a very enduring clinical feature in this environment. So how are we going to start with this? Well, we really want something instructive and sort of have this framework of how we can think about health utilization in the PICU. So we're going to draw from a model and adapt a model that was proposed by Professor Finkelstein, Genskow, and Williams in their 2016 QJE paper, where they were looking at variations in health utilization. And of course, this draws on a fairly rich history in health economics. And really, we're going to try to some degree, simplify this model, but adapt it to the very relevant features of the, or we think relevant features of the PICU. So it's going to incorporate a patient demand component, a physician supply component, and of course bring in regional constraints for our multi-center study. So I'm going to, at the outset, establish that from every perspective within this economic model, the primary goal is to recover a child's health. And so something unusual about the way we approach this model is we really did not specify patient demand as being determined by preferences or tastes. And so intuitively, if you had a child in the PICU, and so we're not talking about end of life or sort of palliative type care here, but if you had a child who was critically ill in the PICU, and this is what we find for most of the clinicians, is really a parent would only have one sort of preference towards their child. It's just do whatever you can to recover my child's health. And that seems to be very, very uniform. That's not saying that's what's going to happen. That's not saying there won't be constraints, but certainly the idea of wanting more aggressive care and less aggressive care is probably not quite as relevant in this environment. So just in terms of some notation and assumptions, we think of a country endowed with I equals 1 to n children, having G geographic regions. And we're going to specify this quantity right at the outset. The child's latent health stock, we're going to call this a random variable theta. And this random variable is a slice in time of a stochastic process, which would be, for example, your human capability, with health capability being one component of this. So this thing is actually evolving through time, but at any given point in time, we get a slice of this, and we have this realization. There's a random variable A, which is just whether or not you get admitted to PICU or not. And in general, in terms of thinking here, all children have some risk at any point in time of being admitted to PICU. So that's some risk of an insult severe enough, or something happening to them severe enough, that they may end up requiring PICU care. And so the key feature we're going to say, of course, is, in our mind, how you get selected to ICU is likely conditional on your underlying health stock. So we want to be really explicit about this health stock. However, and this is clearly going to be an identifying condition for us in our econometric analysis, there are some admissions to PICU that are entirely accidental. And what do we mean by accidental? It means when we look at these admissions, for example, the admission modality of trauma, where children come to the ICU because of an accident, we say, is this truly accidental? Meaning, is there anything about their health stock, anything we can think about their parental investment, anything that's taken place with them that would preclude them or bring them to the ICU in this fashion? And generally, when we looked at this quite in depth and looked at the etiologies, came up with this conclusion, no, actually there are some things that are purely accidental, that everyone is at equal risk, irrespective, not conditional on, but irrespective of their health stock. We're going to define an H of theta, which we're going to call a child's event health status. So again, this is a slice in time, it's a function of their health stock, and it captures their severity of exposure to this health-related event. So this is conditional on A equaling 1. Conditional on being admitted to the PICU. Following the literature, we're going to say higher values of theta represent worse health, and we're going to put a couple of conditions on H of theta. So we're going to start off with our patient demand. We're just going to, again, very simply and almost instructively break it into two components. We're going to say there's a quantity of care, YI, that is matched to their severity of exposure. Secondly, we're going to say there's a quantity of care that is proportional to their underlying health stock. So we're going to use this very simple functional form, but in fact, when we think about sort of disease process or syndrome process in the PICU, we think this is actually very, sort of captures it. One component of the idea of an overuse or an underuse. So for example, a child with an infection comes into the ICU, they require a course of antibiotics. Not giving them the course or an insufficient course of antibiotics would lead to rapid escalation to, let's say, septic shock. However, an overly prolonged course of antibiotics would lead to something like kidney failure. And these are actual sort of examples that we've sort of thought of and worked through. Now, of course, whether they're perfectly symmetric or not, of course, varies case by case, but I think conceptually, it really captures that notion of an over-underuse. It captures the clinical notion of clinicians having this struggle of trying to really identify the right therapy, the right quantity of therapy for the right patient. The second component, of course, ends up becoming a residual component, which is this general notion of complementarity in healthcare, that just the weaker types will require more help, more intense care. So we end up with an optimal condition of correctly matching the level of utilization to the health status. And we're going to say this is sort of forms a normative basis for what we are going to call a need-based approach for the child. And so we're equating the need of healthcare with the degree of severity, and I believe this could be referred to as an extra welfarist type approach to the quantity of care. Of course, the difficulty with this is that medical technologies may not yet be developed for these kind of, let's say, extreme levels of, or unusual levels of illness. So just as a remark, we're just going to start off very simply saying, look, precise clinical identification of the underlying health stock would have important both clinical and allocative efficiency implications. Furthermore, and this is a bit of a leading statement, but precise clinical identification of the underlying health stock really opens up the possibility of what we call a theranostic approach to precision medicine. That is, can I adjust therapy according to the underlying health stock of an individual? Of course, there is going to be a time dimension in that, and as I administer therapy, how does that underlying health stock change, and how can I further then adjust therapy for that individual? So we have an optimal quantity of care for the child, and of course that's a function of their severity of exposure, which is captured by the health status marker, and of course this innate unobserved ability to recover, which is this residual component. So of course now we move to the physician's treatment choice, and again the overwhelming objective is to return the child to health. So the medical care team provides a quantity of care to maximize their perceived benefit. So now we're going to introduce a lambda term which really tries to capture the regional differences in practices. Of course, this is a very active area of research that's really trying to explain this question of, look, we have a lot of observationally similar patients, and they receive really different care in different regions. And what really explains that? Of course, some very recent work by Professor Chandra and Professor Steiger says, look, maybe some centers think they have like a real expertise in using a certain kind of care, and so they're going to use that care. Or we may have some misunderstanding of what standard of care might be. There's many explanations for that, and we're just going to step back, keeping all of that in mind, and say, hey, look, we're going to draw on this clinical investigation of equipoise. So what do I mean by that? Well, prior to running an RCT, you've got to ask yourself this simple question. As a physician or as a treatment group or as a treatment center, are we willing to actually take a coin toss to determine what kind of care we're going to give a patient? So, I mean, we think of RCTs as fairly straightforward in terms of running them, but if you're actually going to run one and you have a proposed therapy, you've actually got to determine when you run this RCT whether or not the people participating in your trial are actually going to be willing to do that. And so that whole process is called establishing equipoise, and until I establish equipoise and I can show equipoise, I can't very well run an RCT. So when we were doing that for an RCT that's ongoing in the pilot trial to see about feasibility, there's a lot of surveys that were sent out. We looked at what individual sort of, treatment choices were, what was going to influence the way individual physicians were going to act, and we saw what the centers were going to do. And then after the pilot RCT, we looked at were there protocol deviations, what happened. And what we noticed from all of this is, just put it very sort of bluntly, there seemed to be this kind of gut feeling that you could see in different groups, where different groups are making decisions for certain types of patients based on some sort of feeling they had, which was saying they didn't have equipoise, but they were going to sort of lean towards one type of therapy or another. And we thought that that gut feeling was coming from whether they thought this patient was really strong, really weak, where did they come from, what was their clinical trajectory. And so for us, it said, hey, you know what? Could it be the case, just sort of thought experiment, that behind the idea of us saying, hey, we're really good at ECMO, this patient looks like a great candidate, we're going to put him on ECMO because we're really good at this. And so, you see these kind of comparative advantage sort of scenarios or perceptions of comparative advantage taking place. What could be driving that is this sort of gut feeling we have about certain groups of patients. And so what we're going to do is say, well, there's some chance, we're thinking that the underlying health stock of the patient does intervene in group practice decision. So we're going to add that term in, which is very different from the antecedent models and sort of explicitly makes this unobserved health stock very relevant. And this, of course, is still, despite, in terms of standard of care, within our sample in Canada, amongst the 6 centers across the provincial jurisdictions, very uniform physician training, everyone being fellowship trained, a lot of cross-pollination, Toronto fellows working in Vancouver, Vancouver fellows getting jobs in Toronto, etc. And in general, I'm going to say a health delivery system that is generally uniform, despite different provincial jurisdictions, basically in the PICU environment, offering very similar kinds of care. So of course, the medical care team is indeed constrained, and they're constrained by institutional constraints. So they're constrained by direct financial constraints. The hospital can't run a deficit. You're constrained financially. There's other constraints here as well, and this is a very nice way we think of introducing things like congestion, and in a way, things like spillover, or the idea that physicians have to prioritize. So in the PICU, patient flow is a big issue. We have uncertain arrivals, of course, uncertain service times, and uncertain sort of discharge ready type of status. And so we really think that there is a congestion factor, of course, that could play into the cost function. Here we specify a very simple cost function, but we do think that these issues, whether we sort of specify these issues through a queuing model or some kind of probabilistic modeling, is certainly something that we would like to think about going forward. So we end up with this optimal quantity of care, and we're going to say this forms a theoretical basis for our main estimating equation. Of course, our primary focus is on the relationship between the response utilization Y star and the severity of exposure, which is a health status marker, H of theta. So right away, of course, the remark is any unmeasured theta would confound a proxy, any proxies that we might think of for the health status. So in current practice, we sort of see illness severity scores, which are very detailed physiologic measures, serving as proxies for the event health status. And of course, the health stock, or this unobserved health stock, this quantity we have, is unobserved. So these illness severity scores are typically objective physiologic measures of the state of the patient. And we're going to look at two of them specifically, the PRISM score and the PIM score, and just give a brief overview on this. So the PRISM score is based on physiologic stability. It's based on these 5 sort of physiologic components. It's extremely detailed. It's about its 4th iteration right now. It actually provides an illness severity score that is combined to provide a mortality prediction. And it's used extensively, and it's been validated as a marker for illness severity. An alternative score is the PIM score. It's got a physiologic component, but of course it's got a few other components here that controversially actually take place after admission. So right away, there would be questions about the objectivity, and yet another confounding issue with this kind of score. This score actually is very simple. However, it does not provide an illness severity score per se. It's just a logistic weighting of these to give a probability of mortality between 0 and 1. However, it is used extensively as well to stratify patients according to illness severity. So of course, the big thing now is, what do we think, what are we going to use as our Y star? What is health utilization? Well, it appears to us that the predominant kind of measure of utilization in a lot of medical literature, and certainly in this environment, are durations. So in the PICU, just the length of stay itself, given the high fixed costs and sort of what we call the high hotel costs of PICU, is just the length of stay by itself. So if you look at many cost studies, they just say 2 days in the ICU is 2 days in the ICU, and they assign a fixed daily cost for the ICU. And I think the estimates are somewhere around 70 to 80% of, let's say, the costs are fixed for all patients. So certainly that seems to be a primary measure in our mind of economic utilization, but of course as clinical outcomes, durations are also very significant measures. So we can think of duration of mechanical ventilation, duration of ECMO, time on vasopressors, time on nitric oxide. So a lot of the analysis we do in the PICU uses durations as an outcome. So now we want to move to an econometric model, and so we want to take this sort of theoretical, what we think is a theoretically grounded optimal quantity, and we want to now specify this econometrically in the presence of a couple of issues now. So we want a duration model to model the outcome, time in the ICU, as a function of the illness severity, which is the exposure. We're going to actually use an AFT model, and I'll just briefly run through the duration models. But our real issue here is that this unobserved health stock creates this unmeasured confounding. Creates it in 2 ways. It actually, there's sort of 3 issues going on here. So it creates it directly in an endogeneity problem in our exposure of interest, the H of theta. It has this frailty term, which in duration analysis by itself creates a problem, an unobserved heterogeneity or a frailty term. And then secondly, we have this other component, which is our regional effect, and we're going to say that that actually is also potentially confounded. We're going to use robust IV, so basically Linda said to me, no matter how hard I look in the STATA manual, I'm not going to find STIV reg, and I'm not going to find ST Cox endogenous. So as far as we know, there was really no way to handle endogeneity in a duration type framework, which is what we're going to do econometrically. So there's kind of 2 big paradigms that you can, that...
There's like Canada law, right?
Okay.
They have estimated treatment effects in preservation.
Right, so the treatment effects are, but are they multi-level treatment effects?
Yeah, it's a multi-state model, and
Okay.
identify unobserved heterogeneity going back and forth between the states.
Right, right. And there's a mixtures approach as well. I guess you can take a continuous finite mixtures approach. So you can model this guy directly, is essentially what you're doing.
So it's just going back to the earlier motivation. So
Yes.
basically, you only care about the kid up to the age of 18, then the kid makes his own decisions. So this is why the utilization is not picking the time of death. So typically in a health world.
Yes. So in terms of continuation utility, or
yeah, so here the parent just wants them to live to 18 as happy as possible, and then everyone's going to make it 18. And
right.
They make their own decisions afterwards.
Yeah, I mean, I think in terms of that point of view, a more, or probably more realistic way of thinking of it is, you want to get them to the state that they come out of ICU. They then go back into a state where they're at risk of going back into the ICU. So it's really like a, well, I mean, I suppose there's many different ways of looking at it, but the way we would look at it is from a short-term perspective within that particular ICU state. Two sort of ways of looking at the AFT model.
What is your justification to use that type of model rather than a proportional
Sure.
mixture model?
Absolutely. So, sort of two paradigms, failure time paradigm, proportional hazard paradigm. What's the difference between the two? All it says is when I have time, how are covariates going to enter? So in the accelerated time metric, covariates enter directly, right? They're going to, inside the surviving function, they're going to stretch out the time. So it's an assumption. So it says, look, my dog's 2 years old. By my age standards, that's 14 years old. My dog ages at a factor of 7 greater than me, let's say. Alternatively, I could say, well, covariates enter by a proportional shift of, in the proportional hazard case, of the hazard. Still, very similar kind of fundamental assumption that you're making as to how covariates enter. Both of these models have a linear representation via a transformation model, where here we have log of t as the y. In the proportional hazard, you would have the log of integrated hazard, and E would be extreme value 1. Under a parametric Weibull model, both those assumptions coincide. So now, why would I pick the AFT over the proportional hazard? So there's sort of three kind of reasons that we point towards. The first is that there's a certain different interpretation of your coefficient. And so in certain kind of studies, like reliability studies or risk adjustment, and this so-called direct interpretation, which Professor Cox actually himself said he would favor in these kind of studies, would perhaps be preferred, as opposed to the relative risk sort of interpretation of your coefficient. Secondly, the literature itself, in the clinical literature, actually historically has used log logistic models, even though, by far, the proportional hazard type models are the most commonly used in clinical and biostatistical studies. This literature, for the most part, so we want to be comparable, but I think the most convincing reason is that in the presence of unobserved heterogeneity, there's a statistics result which is called, I believe, Struthers-Kalb-Fleisch heuristics, which basically says the consequence, and I believe this was work by Professor Keating and Professor Allen, sort of in the mid-90s, that basically said the consequence of omitting a variable, or the consequence of not accounting for unobserved heterogeneity, is nowhere near as severe in an AFT framework than it is in proportional hazard framework. And intuitively, in a simplistic sense, we just think of this as, without having any endogeneity, if you do not account for frailty in a proportional hazard model, you're going to confound the baseline hazard. So you're going to be in trouble right away. So you really do need to account for that. Hence, this massive literature on frailty model. And certainly that is one approach. One could take a proportional hazard model and, of course, think of mixtures approaches or different ways of accounting for the frailty term, or integrating out this problematic unobserved heterogeneity. So for those variety of reasons, we sort of proceed with an AFT model. Now, in general, the linear representation, of course, is very convenient. And I believe Professor Reeder, in his generalized accelerated failure time paper from about 1990, I believe, sort of said, look, when we specify a transformation type model and we specify a linear representation, we've got this really big toolkit from linear normal theory, and it is much easier in many circumstances to try to think of conceptually applying a lot of those econometric methods to this linear representation. And there's been a lot of recent work done in transformation models that have relaxed a lot of things, and really sort of given us a lot of different options in terms of inference. So we're just going to proceed with the AFT model, and with the concept that we have this instrumental variable, which we're going to say was this accidental variable, and if you will, was not strictly a randomized quantity, but was as though randomized. So we've got our log transform durations, we've got S being our confounded observed risk scores. Other concomitants are covariates, and this is going to include a potentially confounded hospital effect. And we've got this unobserved random disturbance, which includes an additive frailty term. So we're going to kind of put that in there, but you would think of this frailty as entering proportionally, and then after linearization being an additive term. So you can make a number of assumptions here. We can say that which is not our case, but we could say if we wanted to proceed in a usual fashion that the concomitants or the covariates are predetermined, the instrument's predetermined, or else we could say the instrument is independent from the error, and we're saying the instrument here is as though randomized. Assumption A3 is something that is a little different. We're going to say that, in fact, the controls of the covariates and the error term can actually be correlated, and that they're jointly independent. And that's because we're going to go with a rank inference strategy, which really relies on exchangeability, and exchangeability allows us to do that. We could go with a fully parametric type set of assumptions, in which case we could do a least squares version of what we're going to do as a rank version, or we could do what the statistics literature calls, for the AFT model, the analogous model to the Cox regression, where we leave epsilon completely unspecified. And we proceed with a distribution-free type of estimation or inference strategy. Of course, we're going to make no assumption on the DGP linking the severity marker and the instrument, or in the functional form of the first stage. So this is going to be an identification robust type inference strategy. So what kind of inference are we doing? Well, we're doing a rank version of the analog to the Anderson-Rubin. So what is this regression? Well, it's not a statistical model, it's purely a computational tool. So what's the intuition? The intuition simply is that, hey, if this quantity, the instrument, first of all, if it's valid, or if it's as though randomized, then a regression of what we call the aligned residuals about the hypothesized beta value, a regression of that on the instrument would logically expect us to see gamma being 0. So the test that we are going to employ is a test of gamma 0, and that's moreover implied by imposing beta equals beta naught in our first model. So that's exactly the Anderson-Rubin procedure, except Anderson and Rubin, they do it in a linear normal model, and the test that they employ is going to be an F-test. So this is a generalization of what Andrews and Marmers proposed in Journal of Econometrics in 2008. And they proposed it for reasons of power. We're actually going to generalize and use the fact that we're doing rank inference here to make it very useful in a duration setting. So they say that test statistics, so first of all, this is not a test of exogeneity. This is saying, look, I'm going to run a test of gamma equals 0, and I'm going to collect all values of the beta naught that are compatible with that test. So I'm going to impose my, for example, strict exogeneity condition, and I'm going to collect all values of my parameter that are compatible with that. So we need a test statistic to do that, and so this actually provides us with a linear rank test statistic, and a quadratic form in that is what we call a generalized Andrews-Marmor test, where the C's are actually what are called rank scores, and then we have the data. So what am I going to do with this test? Well, I'm going to find all values of this test that are not rejected in the test of gamma equals 0. So what do I need to say this is not rejected? I can't, for example, if it were an F test, just go to the back of the book and find the statistics table and come up with 3.84. I'm going to have to calculate that. And the reason I can calculate that is because it is what we call a pivotal test, and it doesn't depend on any kind of nuisance parameters. It really just depends on the data. So we calculate the exact null distribution by simulation methods, and the key thing here is I can use, being a rank test, I can use and draw from any distribution in order to create a cutoff value, or to create really my own statistical table. And then I'll pick the 950th, if I do this 1,000 times, I'll go and I'll pick that value, I'll pull it out. If it were, for example, an F-test, that would be 3.84. Similarly, I'm going to pick that out, following these set of rules. It is distribution free, and then I'm going to use that, and I'm going to search over this statistic and find all the beta knots in a grid search that are compatible with that. Collect all those things. And that is going to be my inference. That will be my confidence set, and that is what, for example, the Anderson-Rubin returns, and that's what we call the generalized Anders-Marmor will return as well. And it really conforms to all of the theory and the work that was done predominantly in the late 90s and the early 2000s on identification robust inference. So there's a lot more to these rank scores. I'm not going to get into it too much other than to say, conceptually for me, I thought, okay, well, what are we doing here? We're taking this sort of, let's say, vector, this n vector of W's. We're taking these variate values. So you actually have numbers, variate values. I'm going to order all these guys. I'm going to take their position. I'm going to throw away their variate value. I'm just going to take their positional order. Now I'm going to take their relative position, and I'm going to reconstruct, using some kind of score, another variate value. And I'm going to use that, for example, in my test statistic. So, well, why would we do that? Why would we throw away what was finer data and now reconstruct data from that? So there's a result in statistics, which is actually very old, by Chernoff and Savage, that say, hey, look, it's all about misspecification. If it were true that the real data generating process was, let's say, logistic, and I use logistic quantile scores, for example, I would be no worse off than if I did the logistic, for example, likelihood approach. But if it were not logistic, and I use logistic quantile scores, and this was shown for many, it was initially shown for exponential scores or the Savage scores, that this had very nice properties when I misspecified the model. So we're going to say, well, our epsilon's misspecified no matter what we do here because of that unobserved heterogeneity that's embedded in it. And so for us, these rank scores, having two of them, quantile scores, expected value scores, were very nice from that point of view. Secondly, these scores allow us to draw on a rich statistics literature of censoring in duration models, so we extend this in a separate paper to include censoring, which seems to be a fairly important requirement in duration models. So I'm going to jump into our clinical analysis. So of course we're interested in the relationship between the length of stay and their illness severity score at the time of admission. We have a data set that was prospectively collected to validate these scores. It was across 6 centers, and it included 2 years of admissions, which actually amounted to 10,000 patients. So in the era of big data, that seems like a really small data set, but of course, in this environment, amongst these patients, extremely rich, extremely unusual. Getting 10,000 PICU admissions.
You don't analyze the probability of rehospitalization?
No, we don't. No. So it's a single event. So the duration is does not include time varying covariates, which it could, of course, be extended to. It's a single duration in a single event analysis. So we will actually, in our clinical analysis, include previous ICU admission as a covariate to control for some kind of that measured factor, but certainly analyzing repeated admissions and certainly thinking of all of this from a process point of view, I think would be where we want to go and would be far more realistic. The way we've approached that actually is via queuing theory, so that we can take into account not only one patient's sort of entire experience, not just through the ICU, but through the entire medical system from a probabilistic point of view, but how that also intervenes on, say, another patient's experience from a congestion point of view, but also from their service time point of view, like their time in different stages of medical care.
Because you could estimate the multi-state, multi-episode model,
Right.
as hazard model.
Right.
Because you're not doing a multi-state, where's unobserved heterogeneity? Again, now you're just that single state. This is where I'm getting confused. Because normally you have the multiple states that back out the multiple, to pull out the estimate of unobserved heterogeneity.
Okay, so
So just wondering,
So our way of accounting for unobserved heterogeneity is entirely through the instrument. So all we're saying here is whether it's an omitted variable or how we view, we're not trying to model the unobserved heterogeneity itself by any means.
but this is something I don't know enough about, but like Joe Churza has all these papers where
Right.
he says if you have a nonlinear model, you should do like a control function
Yeah,
and not an instrument. So why not just estimate that first stage, throw in the error,
okay.
instead of doing predictor substitution? Like, to me, that would be my initial reaction.
Sure.
But
So that, yeah, there was a set of Journal of Health Economics articles by Terz, I believe, that, I forget the name of that estimate, but yeah.
QSRI.
Yeah, that's
It's
it.
the worst name of it. But
Yeah.
I think control function sounds nicer, but I guess that's one.
Yeah, I mean, we certainly started with many different approaches, and of course, Marcel and I think looked at these kind of approaches. We looked at continuous finite mixtures. We looked at modeling directly the heterogeneity. But then we also found it very instructive to just think of sort of the problematic component of the unobserved heterogeneity, which here we think is predominantly not only that it exists, but that it's actually endogenous. So it causes an endogeneity problem. Which, yes, our solution is just simply to instrument in this case. So go straight into the clinical model. We include some other covariates, the number of chronic diagnoses a patient might have, whether they were, and so that'd be 0, 1, 2, or 3 or greater, whether they had previous ICU admissions, their age category, and whether or not they were cardiac patients. So we don't include any kind of treatment or anything they might have received after they entered the ICU. And of course, our instrument here is a 0-1 indicator as to whether you were admitted to the ICU via trauma. So we do, I guess that's a little bit off. You can probably see most of it there. So we sort of think, well, what would we do initially without any kind of correction? We would just directly use these scores in the same regression. And we would do, let's say, an AFT parametric kind of likelihood-based INS data. And we report the 95% confidence intervals here. So we say, I use PRISM directly. I look like I get very precise estimates. And what does this tell me? It says, well, incremental changes in PRISM probably result only in about a 7% change in length of stay. Whereas if I directly use PIM, incremental changes in PIM result in about a 25% increase in length of stay. So both very different, feel very confident about these results. And it turns out these are almost exactly the results that have been seen in the clinical literature, and the latest work by Pollock publishes this as the attributable effect of PRISM on length of stay. So very little effect, but very precise sort of estimates of it. So we can naturally move to something like a gamma frailty model, and we see those effects still being very precise, but changing a little bit. So then we move down to these sets, or the last 4 sets of confidence intervals. And so here the confidence intervals are size controlled, and they reflect, of course, the sampling uncertainty in the data, but they also reflect the so-called radical uncertainty about the identification status of the model. So really, if our instrument trauma has really very little information on severity, then we would see very wide confidence sets. Similarly, if it turns out only a very small portion of our population is actually our sample is instrumented, we would still see that variability show up. Sure.
So how do I interpret the fact that the Anderson-Rubin ones don't overlap at all with the AFT ones? Like normally I'd expect bigger confidence intervals.
Right.
But I expect one to be subsumed by the other one.
Right.
And there's 0 overlap.
There's 0 overlap. So there's 0 overlap with the likelihood-based approach. And there's, we get even further away when we go to a rank-based approach.
No, but like typically, like you're centered on the parameter estimate.
Right.
Basically, the parameter's also changing. Is that what's going on here too?
That's a good question.
Because That's where I'm struggling right now. 'Cause I can see why it's getting bigger, but I just don't see why.
Right. So maybe if I had just, yeah, I don't know. Actually, that's a good question. I'll have to ask Linda about that. We've never had that come up, actually. That's very interesting.
Yeah,
I mean, what we found very interesting, what a lot of people bring up is the fact that the correction moves in one direction with Prism, it moves in another direction with PIM, which we found very interesting.
we never overlap.
So you would expect that these values are centered on, the, for example, the least squares.
Yeah. Like what's worrying me is if you're doing something so computationally challenging,
Right.
that something weird is going on. Like it's just
And then,
let's be very harmless.
okay.
Start off with just the least squares, or like what was going through my mind was you have two groups. You have people who come by trauma and people who don't come by trauma.
Right.
And you see them over time.
Right.
Let's maybe think about it as like a non-linear diff, like a change in change. So you can estimate
Okay.
the CDFs of length of stay. And that way there you can basically, so you have 4 CDFs of length of stay. The nice thing about the change in change stuff is you don't need common support on observables, so it could be
Okay.
very different groups in that way. But then you can estimate treatment effects on length of stay from very small to large.
Right.
And then you can bootstrap the standard errors, ta-da.
Like multi-level treatments in terms of different severities amongst the two different groups.
Yeah, you could, yeah, so that could be like, that could be your pre-post,
Okay.
pre-post, it could be like low severe, high severe, whatever.
Right. Okay, but in terms of these results, you sort of have this worry of some spurious type results.
Well, yeah, because
because,
like 95% confidence intervals that aren't centered on the same things just scare me. I don't know.
okay,
They don't overlap, I just don't know, and there's just overlap, right? It's the same prism. This is what just worries me.
okay, so the overlapping is a function of, let's say, if this inference was completely off, irrespective,
Yeah.
I should still see sort of the overlapping of the sort of consistent estimator
Yeah,
component.
because if you have a consistent estimate from all of them, it shouldn't be jumping that much.
Okay, so under endogeneity, is this consistent? This guy up here? Like if it's endogenous, how is this consistent?
Okay, so that, okay. Okay, so that one is, okay.
So like these two, okay, so maybe, so these guys, let's just forget about the frailty model. So
Okay.
this guy, let's say I went in and I did linear,
Yeah.
just, I transformed it, I did a log normal, so now it becomes just a linear IV.
Yeah.
So what I'm arguing, what would that be? That would be this guy right here, right? So that's a least squares, let's forget about likelihood, that's a least squares linear IV.
Okay.
So if it truly is endogenous, what do I think about the consistency of this guy?
Okay. Consistent.
So if that guy, so like this guy's inconsistent, right? If it isn't truly
Yeah,
endogenous.
so let's say that points in effect is 0.069. Now, the other one is tripling in size, it's scary me too, right? It's usually a sign of a weak instrument. Is basically when you think you reduce forms by the first stage, so weak first stage blows up your IV estimate,
Right,
which is down there.
right.
Essentially,
So-
that's 3 times. So
Yeah, so
there's
okay,
something
so
funny going here, that's all.
yeah, so what we did is we actually just said, okay, forget about the duration part. We just transformed it, we did a least squares, we come up with this guy here. And then we said, let's just do IV reg. And let's go out, and then let's do post estimation. So what do I get? Well, I got a first stage F statistic of 17 on this guy. But on this guy, I got a first stage F statistic of around 500. It's like way up there, right? So then we started saying, well, look, it's the same instrument, and we've got a whole section that came up and said, look, a lot of the features empirically are going to say that depending on the endogenous covariate here, this guy right here, you're going to have different results from your instrument. You're going to have different results from your instrument because you're going to have different instrument balance, kind of like what you're alluding to. You could have a small group that was trauma, a large group that was not trauma. A lot of that information, though, we feel is revealed by these confidence sets. So in terms of the overlap, I can forget about that part?
Yeah,
Okay.
because they're the one thing consistent, the other is consistent.
Okay. So what are we going to do with this? We're going to say, well, first of all, if you're directly going to use these guys and you're directly going to use them in, for example, risk adjustment or any kind of policy thing, you should probably be cautioned from doing that. So people do actually use these scores. And then what we're going to do is say, well, what are we going to do now for proxies for H of theta and for theta? And so sort of having worked this up with what we have in terms of available scores, which are still fairly detailed, can we move forward but with the framework that we have for conceptual purposes? And so that's where we're going to think of what we're sort of embarking on now, and I'm going to just do this very generally for the last few minutes here. So what are different proxies that we can think of for H of theta, which is a severity measure, and then theta itself for the underlying health stock. So we're working alongside a gene expression component or a precision medicine component of one of the RCTs we're involved in, which is specifically in a pediatric septic shock patient, septic shock patient population. And we're going to use different forms of quantifying of gene expression to in a sense, proxy these markers. So we're going to use the Persevere model, which is based on two components. There's a protein or serum protein component. There's also a mRNA gene expression component in that. And that would, in our mind, sort of proxy the illness severity score, and again, theta inside the illness severity score. And then we're going to use two different types of sort of bringing together gene expression information via endotyping and via a gene expression score. So conceptually, we're going to think of sort of thinking in terms of our economic framework, our econometric framework, but now try precision medicine markers in that framework. So our initial look at endotypes and illness severity scores, just trying to compare them just as markers. When we're in an exercise of prospectively validating the endotypes, where we just come up with two groups. So these are two groups that comes from all this gene expression information. We find that for observationally similar PRISM scores, for the two groups that have different response to, in this case, adjunctive steroid treatment. So observationally, these guys are the same via PRISM scores. However, when we look at their clinical course and certainly in terms of their health utilization, they have very, very different outcomes. So what would have otherwise been observationally the same in terms of risk stratification, we now see quite a difference in. And then furthermore, we see different clinical outcomes in response to adjunctive treatment that might take place because of knowledge of A or B, which previously might have only taken place because of some risk stratification based on the PRISM score. So very basic kind of stuff, but it's sort of a first step in this kind of environment. So going forward, we sort of have these real motivations and challenges, and the first of course being that we're really talking about heterogeneous syndromes and not disease-specific type of scenarios, which is a very different sort of application from what I understand in precision medicine. Rapidly changing health trajectories, and obviously we are wanting to keep in mind this is all to try to target high-risk therapies to the right patients in order to get that therapeutic efficacy. So our objective, or short-term objective, is to really model what we have collected as endotype transitions during certain acute phases of shock, and sort of see if we can start building a bit of a time path for that health trajectory. Of course, all of this would be working towards what we call a theranostic approach to septic shock, being the idea that we can really tailor treatment and see the results of treatment real time, very quickly, and continue to adjust the treatment to that real time sort of information. So in conclusion, we think we had a clinically relevant question. We think it has useful economic implications, sort of have a theoretical model to motivate our econometric analysis and some of the challenges that we might have. I think we proposed a novel method of robust inference in a duration framework. We, of course, extended identification of robust IV to duration analysis. And we'd like to think of this framework as starting to think of a way of validating we'd like to validate this framework for future precision medicine type initiatives in the PICU. And really the takeaway from econometric analysis is that direct use of currently available illness severity scores likely masks the attributable effect of health status on health utilization. That's it, thank you.